risk, moderate risk, or a low risk. Low risk people have enter the bowel cancer screening program. Those with a family history will have more frequent screening or better screening of some sort. We know if we screen people in this way, then we can reduce the risk down in people who don't have Lynch syndrome down to the average risk, so about 1 in 20. So they might start with their lifetime risk of about 20 or 30%. So by having a colonoscopy once or every 5 years after they're 50, then we can reduce that risk down to about 5% again. So it's the thing with bowel cancer is that, you know, which makes us very fortunate, is that it's one of the cancers, probably the cancer for which there are the best array of screening tests available and the most effective. So so we know that for years, for example, in prostate cancer, people had screening, particularly in the United States. It's no longer recommended on either side of the Atlantic because what they identified in people who were screened for prostate cancer was that although there were some prostate cancers found, the overall incidence and survival didn't change one little bit. However, the consequences of screening, so people ending up with incontinence because of procedures, for example, very much did increase. So on the basis of 2 studies that were done on either side of the Atlantic, it's no longer recommended for average risk people. And then if you look at Lynch syndrome, then having colonoscopy every couple of years from your mid-20s onwards has a very significant risk, influence on your risk of bowel cancer over your lifetime. It doesn't decrease it down to 5%, but it may improve survival. This is extrapolated data, so there hasn't been a clinical trial as such, by as much as 82% mortality benefit. So there are a number of conditions here, not just Lynch syndrome on this table that we think about in clinic. FAP is the one that we've probably known about for longest. Lynch syndrome, lots of other, mostly polyposis syndromes. And these are the genes which cause the syndrome. So lots of things that we consider testing for. FAP is characterized by people having thousands of polyps, typically or classically, in the large bowel. Lynch syndrome was once known as hereditary non-polyposis colorectal cancer. And we know that there are polyps in Lynch syndrome, so that, we can characterize it genetically now, whereas originally it was identified by understanding family history. So the name's changed back to Lynch syndrome. There are probably, we estimate, maybe 1,000 cases of colorectal cancer due to Lynch syndrome in the UK every year. This is a big family from Galway in the west of Ireland. Not my family, fortunately, I'm lucky enough to say, but a family I knew back at home. And this is a family tree. I don't know if you've seen any of the family trees today yet, but the people with the squares and circles filled in are men or women, males and females, with bowel cancer. And those with the dots in the middle had other kinds of cancers. And this is the kind of classical Lynch syndrome family. Many families don't look like this, however, and we know, Ian was talking about how difficult it's been to identify families or people or individuals affected with Lynch syndrome in the UK. This family has an MSH2 mutation. So how do we manage people in whom we suspect may have a Lynch syndrome cancer within our MDT, which is our multidisciplinary team? Well, we have to know whether we're looking at the right kind of patients. So we maintain a patient registry so that we're screening the right patients at the right time and they're followed up appropriately. We don't rely then on patients being referred by the GP because they're worried. We know about the families hopefully in advance by maintaining a registry. That's the ideal. And then we offer screening and surveillance at appropriate times. And we consider testing for Lynch syndrome or recognizing polyposis at diagnosis. And then further down, there's a smaller proportion of people who will need to have genetic testing, depending on what's happened before. Polyposis may be relatively rare, certainly rarer than Lynch syndrome. But we consider if somebody has more than 10 polyps in the colon on one colonoscopy procedure. Lynch syndrome, on the other hand, we need to consider at least in about 1 in 5 patients. I won't spend too long talking about this because I know Ian did earlier on. But that's because they fulfill testing criteria called Bethesda. Now, that would be that they're diagnosed before the age of 50, or because of a family history, or they're diagnosed under 60 and the tumour looks a certain way to the pathologist. When we go to the MDT, many MDTs look a little bit like this. So lots of people in a room, maybe sitting around a big table or in rows, looking at a screen at the top of the room. Who sits in the MDT? Well, there might be a gastroenterologist. So we're often more involved in the diagnostic stage of the patient's pathway. However, we might be involved in, for example, inserting a stent later on, or we might offer a family history service, for example. The colorectal surgeon, obviously, most colorectal cancers will go under a surgeon's knife, and a large proportion will also be seen by oncology and treated with chemotherapy or radiotherapy. The colorectal nurse specialist is a key member of the team, often the kind of single point of contact for patients, and helps to coordinate patients' care, and may also increasingly be following people up in a stratified care pathway. A pathologist will sit in the MDT, will show slides on the screen, and try to characterise the tumour, because some tumours, for example, are susceptible to certain treatments and some are not. A radiologist, everyone will have a CT scan, and you may have an MRI if you have rectal cancer, for example. So the radiologist will put the scans up, we'll all have a look at them, and they might be able to pick up on things that other people haven't picked up on before, and we're putting that into context in a team-based way. So the treatment essentially depends on the biopsies that the pathologist looks at and CT scan or MRI scan. Almost all bowel cancer treatment depends on those tests. So we sit together and put all those test results in context. And then there's palliative care, stoma nurses, administrators, junior doctors, so lots of people potentially at the MDT. And pretty rarely a geneticist. I think there are only 61 full-time equivalent, correct me, but I understand the workforce assessment that there are only 61 full-time equivalent clinical geneticists in the United Kingdom. So they are, and they look after a lot of things. So, and that's probably part of the reason why, as a trainee, when I was going around different parts of the country, I never once sat in an MDT and felt that this was done very well, even at generally otherwise very good centres. And I think that increasingly, other people need to take an interest in conditions like Lynch syndrome. And this is a colorectal cancer MDT. Obviously, we're not thinking too much about gynecological cancers or other cancers in this setting, which can become an issue.
So,
yeah.
How long does it take for a team together to actually operate on a patient?
This meets weekly.
Will it just take a few weeks, a few months?
So everyone's supposed to have their treatment within 62 days. That's the target.
Yeah.
So 62 days. And that's from referral from the GP.
Yeah.
So they wait a couple of weeks for referral to be seen in clinic. Then they might go for the test. A few weeks later, then they might need more tests. Then they go to an MDT. Then they're seen in clinic. The treatment is discussed, and then they will start the treatment. So that takes a bit of time. So there are things like straight to test that I was mentioning, which is where increasingly we're trying to get GPs to refer directly for tests, provided that the patients are assessed appropriately in some way. So we're constantly thinking about ways to shorten this pathway as much as possible.
Kevin?
Yeah. Sorry, yeah.
If you have Lynch syndrome and you're worried about symptoms, is it best to go to your GP, or is there someone at the hospital you can contact? Sometimes it takes quite a long time to actually get them to pay attention.
Yeah, I know that is an issue. It's tricky, and I suppose most GPs won't know much about this, and they've got a lot on their plate. I suppose you can go armed with information. A clinic letter from a hospital stating they have got Lynch syndrome, and that should be enough for them to trigger an urgent referral. And generally, you probably will, if you have Lynch syndrome, be known to a service which is following you up. And they, if you were one of my patients, I would want to know I give my email address out to all my patients.
And with the symptoms like bleeding and abnormal bowel habits, how long would you need to have that before you can start getting work?
Well, that's a good question. I mean, there are lots of things that can cause that, but I think if you've got Lynch syndrome, then you can get a tummy bug. People get tummy bugs. So if you have vomiting and then diarrhea and it settles in a few days, then there's probably not much to worry about, because people will get those, and that's very typical of a tummy bug. But any other cause of diarrhea, I think you need to discuss it with the GP. Bleeding of any kind, fresh bleeding, dark, altered bleeding, it should be discussed with the GP or with another health care professional. I think of any length. So this is the pathway. So it's a complicated pathway. This is the first part of the pathway. I'll walk you through it. So this is our local cancer network pathway, which is the London Cancer Alliance. So the patient is referred. They might get a straight diagnostic test, mostly not just at this point in time. That might be a sigmoidoscopy, a colonoscopy, CT, colonography, or other test. Once the cancer is diagnosed at that test, then they have staging with CT, MRI, and then a colorectal nurse would be alerted, and they probably be discussed at an MDT at this point, and then they'll probably see a surgeon in outpatients, and they'll discuss surgical options, and then the surgical resection specimen will be analysed by the pathologist, and then they go back to the MDT. And we're picking it up, right back here, back to the MDT, follow-up surgical clinic, and then maybe the oncologist will see at that point and start chemotherapy, unless you're having chemotherapy prior to surgery, of course. So lots of steps, but at least there's a coordinated approach to trying to manage new bowel cancer diagnosis. Colonoscopy every 2 years from the age of 25. I know this is something that's kind of a key issue for many of you. Is this the right age to start? My feeling is that probably it is, yes, because you have to balance the risks and the benefits of any screening procedure. A study that was published by a group in Australia recently looked at cancer risk in individuals with Lynch syndrome at different ages. And basically what they identified that if you screen people in their 20s with colonoscopy, you can prevent one death for every one serious complication that occurs as a result of colonoscopy. So I think that we have to be cautious, and although the risk of colonoscopy is for a diagnostic test about 1 in 1,000 of the cause of bleeding or perforation, which is a tear in the bowel wall, when you're screening, you're offering a diagnostic test to otherwise people who don't have any symptoms. So you have to think about what the proven benefit of that test is before you proceed with it. So I think if you screen people earlier than 20, 25, then you have to be aware that your risk profile is probably increasing, whereas your likelihood of identifying cancer is decreasing. And you have to be more aware perhaps at a younger age of symptoms. I think that the evidence that we have for screening is very important for that reason. So I've been using dye spray, which is we perform a colonoscopy, spray the inside of a bowel. It's also a form of what's called chromoendoscopy, so there are different forms of chromoendoscopy, and dye spray is one. And there have been a number of reasonably small studies that suggest that you can increase the number of polyps that you identify in this way. And the European Society for Gastrointestinal Endoscopy now recommend the use of dye spray for screening patients with Lynch syndrome when you have a colonoscopy. So this is a late 2014 guideline, and we've shown in our service that it certainly does increase polyp detection rate. And it's thought studies in the 1990s, authored by Hans Vassen, who's a leading guy in Holland. They extrapolated that having colonoscopy every 2 years from your mid-20s probably extends your life by about 7 years. So it's a fantastic test. It's fantastic to have such a test available, and unfortunately many other cancer sites were not fortunate in having screening tests of equal efficacy. And then there's the issue of hysterectomy, which I think you had a discussion about earlier on. There are other screening methods: CT colonography, flexible sigmoidoscopy, other stool tests, FIT, which is immunohistochemical testing, and DNA tests in the stool. But in Lynch syndrome, there is no substitute for colonoscopy and dye spray. Absolutely none. I would accept none. So CT colonography is not a suitable screening test, in my view, for Lynch syndrome patients, although it's an excellent screening test in many other respects. These are some lesions I've identified in the last month or so in Lynch patients. This is dye spray colonoscopy. These are magnified images. This is about 0.5 millimeter in size as polyp, so easily missed at colonoscopy. There's a couple here, also very easily missed. One here, one over here. This is probably the most obvious, the top right here. Sorry. Well, what I will say is that there hasn't been a really good randomized controlled trial. Personally, I favour it, but I think that I'm cautious about the use of dye spray, and I wonder whether part of the reason that people benefit from dye spray is that when you spray the colon with dye, you spend about 60 or 70% longer than coming out of the colon than somebody who doesn't use it. So withdrawal time is typically about 11 minutes of the colonoscopy. When we use dye spray in our centre, it's about 19 minutes. So we're spending longer looking at the bowel. So that might be part of the reason why it's better. And so Ian mentioned it earlier on. So the bowel cancer, so the National Screening Committee of setting up a subgroup looking at screening mutation-proven Lynch patients through the bowel cancer screening program at bowel cancer screening centres. So that's one way to improve the quality, because the bowel cancer screenings are generally have higher accreditation. As part of that process, we're developing plans for a randomised controlled study comparing use of dye spray or standard white light, which is just standard light that we use in patients entered into screening through the bowel cancer screening program in this way. So we're going to try and identify clearly whether or not this is of benefit. Sorry, Tracy.
I've never had dye spray eye myself, but is it something that you can request as a LS patient?
Everyone with colitis or extensive Crohn's colitis for more than 10 years should be offered dye spray colonoscopy regularly when they have their surveillance colonoscopy. So everywhere in the country should have dye spray available.
Right.
I'm not sure how many of the inflammatory bowel disease patients are having dye spray.
I've never had it in 10 years.
So it might be somewhat variable, but everywhere should have this available now.
Yeah, you said it was introduced or recommended to be introduced in July last year. So if I've had 3 colonoscopies. My last one was about 4 months ago, and dye spray was used then. So it's perhaps that it's just been introduced.
That's terrific. And there are obviously lots of guidelines that come out, European, so we need to maybe consider British guidelines, for example, to really pique people's interest. And guidelines are an aspiration, but they need to be performance managed in order for them to be effective. And that's the bottom line.
I'm a colorectal nurse specialist, so I work with the gastroenterologist quite a bit, and one of the things I'd say is if you were going for your procedure, different colonoscopists may not be familiar with the technique necessarily. The gastroenterologists may be more familiar than the surgeons are with using it. So maybe if you're going for your screening colonoscopy, it's worth phoning the department and saying, am I on a gastroenterologist list who can do the dye spraying? That might just be a way, whilst it's filtering through for everybody, because it will come in time, but it will be just a training issue potentially.
Yeah, it does. It takes time, and you know, we had a new surgeon who works in another centre. Who's very, very good surgeon, an excellent surgeon, and he called one of my colleagues into the room and said, "What's all this about dye spray?" And they said, "Well, it's this," and he went, "Right, okay." And he just carried on. I don't know about this newfangled thing.